Here we go. So we're going to start on slide 21. Where we left off. And we were talking about the wavelengths of the X-rays that come out of the machine and the differences between those wavelengths and why some have better penetrating power, why some are like stronger or quote unquote better wavelengths for taking X-rays. And the reason is because they're either short with a high frequency, meaning they're like higher energy and they penetrate better. So they get the job done. They give us a better image. They get through the tissue or the teeth, whatever it is, and they get the job done. Or we have these long, I call them long and lazy, kind of low energy wavelengths. We don't want those. And I think we talked about this slide, but you can see here how it's showing, like if this is the cross section of say a tooth or something, you can see how the longer wavelengths, the low frequency, longer wavelengths, they don't penetrate. And then as you increase that and they get shorter and closer together and the frequency increases, then they penetrate and might go all the way through. And this also is increased as we increase the KVP. So if the KVP is low, then they're not going to be as penetrating or as high frequency, shorter wavelengths. So KVP has an effect on the penetrating ability of the X-rays. Okay, so filtration. So what is filtration needed for? So filtration helps us weed out those X-rays that are the weaker ones that are just going to cause a biological effect, but they're not actually going to help give us a good diagnostic film. So it's selectively absorbing out useless low energy X-ray photons. The half value layer is the thickness of the absorbing material. It's usually made out of aluminum. So you need to remember that. That's important to remember that it's made out of aluminum. And it's the half value layer is the thickness of the absorbing material necessary to reduce the X-ray intensity by half of its original value. So you might be like, why would I want to reduce the intensity? Don't I want higher penetrating, better, why would I want to reduce it? But really what you're doing is you're reducing the unneeded wavelengths. So it's not so much that you're taking away half of the good ones, you're just taking away the unnecessary ones that don't really give you any benefit. So important, you can star this here. The filter is just like go ahead. So KVP affects the wavelengths by, if you increase your KVP, you dial it up the power, then you're going to be generating shorter wavelength, higher frequency, better penetrating X-rays. The lower your KVP is, then they're going to be long and lazy, not as penetrating. Kind of makes sense. Think about, you turn up the power, they're stronger, turn down the power, they're weaker. Kind of, you can think of it like that. So the filter is literally just a thin sheet of aluminum. If you look down the barrel of the PID or the BID and you just see metal, you're pretty much looking at the filter. And that filter is going to vary in thickness depending on the KVP of your machine. So we learned last week that our machines are all set at 65 KVP, except for our one oddball brand new one, which can be set at 70. It was so much easier when I could just lump them all together and say, all the machines are the same in our clinic, but now we have this other one. But anyway, so if our machines are set at 65 KVP, do you think of the aluminum filter on them is 1.5 millimeters or 2.5 millimeters? 1.5. Yep. So star that. You want to know that information for the exam. So now you might say, well, what's that new one, 1.5 or 2.5? I'm going to assume it's 2.5 because it can go up to 70 KVP, but I actually do not know it for a fact. But that's just my educated guess. But if your machine is set at 69 or under, then the thickness of the aluminum filter will be 1.5 millimeters. So it's pretty thin. I mean, that's very, very, very thin. And millimeters will resonate with you guys very soon because you'll be looking at the periodontal probes, which are in millimeters. So you'll see really just how thin that is. But you can see here's a cross section of the aluminum filter, and you can see how these long kind of lower frequency, longer wavelength, they disappear after they go through. So it just absorbs them, just takes them in, absorbs them. So collimation, so all of these things, the filtration, the collimator, the lead-lined PID, all of these kind of do things to give us the best X-ray photon in the end that we want. So it helps to direct them to where we want. It keeps them from scattering. It absorbs. So it does all these things. So these are all kind of related to X-ray safety and patient safety because they're all things that kind of get rid of the stuff we don't want and keep the stuff we do to get it to the best X-ray photons for our use. So collimation is another thing that's in the tube or in the X-ray tube. And again, it comes right before the BID. So the filter and the collimator are sandwiched right at the exit. So the X-rays have hit the anode and they go through that little vacuum tube and they're coming over here to this window where the BID is connected, but they have to pass through the aluminum filter first, and now they have to go through the collimator. So they're sandwiched together. So if you can visualize that, and then you have your BID coming off of that. So the collimator or collimation, it controls the size and shape of the beam, and it's made of lead. And so it's everything that hits it everything's going to be absorbed. Long, short wave, everything that hits the lead part of it. And then the diaphragm, the opening in the center, it's like a donut. Whatever gets through there is restricted down to just a certain stream of X-ray photons that get through that center part of the lead diaphragm or the lead donut, whatever you want to, however you want to describe it. But you can see it here. Where's my, oh, I have to use my finger. So you can see it here. So here's the collimator B, and it's up against the PID or the BID at the back toward the tube head. Now it can be a circular collimator or it can be a rectangular collimator. Ours are, what are ours? Rectangular. So it's a piece of lead shaped like a rectangle with a rectangle hole cut in the middle. Okay, so what is this showing me? So this image shows, image shows the exposure kind of ray of X-rays if there was no collimation. So as the X-rays come out of the tube head, as they're exiting through, they come off of the anode and they come through that little vacuum tube and they're coming down the BID. If you had no collimator, our X-rays go in a straight line, but they fan out like we talked about. So you can see how much of the patient's face is being radiated. So you can see this triangle is very wide from the tip of their nose to, past their ear and, this part of their head. Whereas if we add a collimator, it narrows it. It's still covering the film. It's covering the exact, area that we want, but they're not getting any on their nose. They're not getting any on their temple or any of that, whatever part of their face. So it restricts the size of the beam to just focus it right over where the sensor is, where we want it. So you can see here the difference of the excess radiation. So if, all of this is limited. So we have, the patient receives about 50% less radiation with a rectangular BID, or just with collimation in general, they receive about 50 to 60% less radiation. But the rectangular, you might think, why in the world do we have these rectangular ones in our clinic anyways? Because in practice, and dental assistants, you probably can confirm this, I never worked in an office with a rectangular BID. Did anybody use one in practice? Oh, you did? Prove me wrong. So they're out there, but they are just not very common. And why do you guys think they're not as common? It's harder, it's easier to cone cut with a rectangular. It's harder to use. You have to be much more precise. So they're just not as common. So, but we have to, a couple of reasons why we use it is because if we teach you the hardest way first, you'll probably like kill it in real life. And then also your patients, you're going to inevitably take retakes, and you'll take more retakes now than you will later. So we want to, if we take 9 retakes on a patient with our rectangular BID, they're still probably getting less radiation than normal dosing out in the world. So we're still doing, we're not harming our patients with all the retakes that we have to take on them anymore. It's any more radiation than they would normally probably get. So that's why we choose to do the BID. I had the hardest time getting used to that thing. I was like, why do we have these? But now it totally makes sense to me. And the more you practice with it, it typically gets a little better. Okay, so did I want to say something? I have other notes here, but now I don't know what my notes were. The long BID, they're preferred because there's less divergence of the X-ray beam. So it kind of, and that divergence is like that spreading out. The longer the BID is, we have, that new one has a very short BID. It's like super short. But theoretically, when the X-rays come out and they diverge and they fan out, if your BID is longer, it kind of keeps them, it keeps them corralled. I think of it as kind of keeping them corralled. And so it helps keeping them on that path that you want them on. Another nice thing about the rectangular collimator, twice as many film. Okay, but we talked about that. Okay, so here's just another image of the X-rays coming off of the anode. They're going through the lead filter here. They're going through the, no, so sorry, aluminum. They're going through the aluminum filter, and then they're going through the lead collimator. And then you can see how it restricts the size, and then the longer BID kind of helps to keep this divergence from being too broad too soon, because you can see how it spreads out pretty fast. I mean, it's just gonna do that anyways. But the longer BID helps to control that. Okay. Yeah, question.
The kilometer and the length of the BID basically determines how the path will be, or the X-ray is going to be.
Yeah, it helps to restrict the size of the beam. So if you have the collimator and a longer BID, it kind of helps to restrict the size, because you really just want it to cover the, ideally it would only cover X-ray over the sensor and nowhere else. But we're going to get X-rays other places, but those are things that help restrict it. Mm-hmm. Yeah.
So I like to label my pictures, but for the picture before that,
yeah,
where in that picture is the aluminum?
This, can you see my cursor? Is it showing up? Yeah, it is. So this right here is the aluminum filter. This is the aluminum filter. And then the next circle here is the lead collimator. Mm-hmm. Okay, so now this is a little bit of a confusing part, talking about the scatter. So bear with me. We'll go through each piece, and then I have a final slide that sort of puts them all in one slide so you can see them, because it's a little bit confusing. So primary radiation, it's the penetrating X-ray beam that's produced at the target on the anode that exits the tube head. That's primary. Sometimes we call it the useful beam. So that's going to be your primary beam, your useful beam, and it's coming off of the anode. So it's happening internally inside of your X-ray machine. Secondary radiation is created when your useful beam or your primary beam interacts with anything. Not the collimator and things like that, but mostly once we call it secondary once it hits soft tissue or the patient's face or something like that. So I guess I should clarify that. So secondary radiation created when the primary beam interacts with matter. So scatter radiation is basically secondary radiation. So scatter is secondary. It's a form of secondary radiation resulting from an X-ray photon that's deflected from its path by interacting. So those terms are kind of, I don't know, I feel like they're kind of the same thing, secondary and scatter. But I'm not going to quiz you specifically on that. I think those two things kind of confused. I noticed last year when we were going over this, people were like, well, what's the difference between secondary and scatter? And I was like, well, they're very similar. It says it's a form of secondary. So don't think too much about that relationship. Just know that that kind of lives underneath secondary. Then we have the two types of scatter radiation. So radiation can only do a couple of things. When it interacts with matter, it can only either pass through, like not the photon doesn't hit any electrons. It just manages somehow to make it all the way through. It just passes through. Or it is totally absorbed. It bunks into an electron and it uses up all of its energy and it's totally absorbed. Or it scatters, which you can think of in terms of I don't know if this is a good idea to compare it, but I kind of want to. But I kind of compare it a little bit to Bremsstrahlung, because when you're creating Bremsstrahlung radiation, one electron can create multiple waves, it can go on until it's done. So it's the same thing with scatter. You can, one bit of scatter radiation can have a little reaction, and then it can go on and have some more reaction until its energy is all used up. So those are the only things that secondary radiation can do. It can pass through without any effect, hit the sensor, and then you get how it looks on the sensor, be totally absorbed, never hit the sensor, that appears differently on the sensor, or scatter. So scatter can also contribute to fog, because you're gonna get lower frequency radiations from scatter. If it's bouncing around and using a little energy, but then it can still go on and have an effect on another cell. Fog, and we'll talk about that I don't even know if it's this lesson, actually. Sometimes I jump ahead of myself, but the quality of films, sometimes they have like this foggy look to them, and that can be from scatter. But don't worry about that. That I think comes later. Okay. So secondary radiation that passes through with no interaction, producing a dark area on the film. This is called, we talked about these terms a little bit already. Radiolucent, I think of translucent. I think like it's dark on your X-ray, it shows up dark. I don't know why translucent helps me think of that, but I think it's more because of the other one, radiopaque. Opaque is white, and so I think of that leads me directly to white, and then the opposite is black. So that's how I've remembered it. But if secondary radiation, if it passes through with no interaction, it hasn't lost any energy, and it hits that sensor full bore, you're getting all the power, and so then you're going to get a dark spot on your film. So an example of that would be if it goes through something that's more soft and tissuey, like the pulp, periodontal ligaments surrounding the tooth, between the bone and the root of the tooth, the periodontal ligaments. Just airspace is going to show the darkest. And then this is just a picture of it. So the X-ray photon comes up to this cell of whatever it is, this tooth cell, or and it just passes straight through without interacting with anything, and it just keeps going until it hits the sensor. So the next thing would be is if it was absorbed completely. This is also called photoelectric effect. So it's just another name for being absorbed completely, and that's when the transfer of energy from the X-ray photon to the atom, or whatever the matter, whatever it hit, it is absorbed completely. This happens about 30% of the time. So it's common, of all those different ways that the X-ray photons can interact. This happens, a third of the time. So that's pretty common. And this produces the light or the white areas on the film, which we would call radiopaque. And so that could be in various amounts because you see the shades of gray. So the bone, different amounts of lightness. You see kind of the webbing in the bone. You see the enamel is very bright. You see dentin is less radiopaque. You see things that are metal are the most radiopaque. They're fully absorbed, so they never make it to the sensor. And here's an image of photoelectric effect. So the X-ray photon comes in and it's totally absorbed by this K-shell electron. And then that's it. That's all the lifespan that it has. That's all it will do is just be absorbed by that electron. And that photon never makes it to the sensor. Now we'll talk about the biological effects of this because when this X-ray photon, well, never mind. No, I'm not going to get off track. I'm tempted, but I'm not going to do it. Okay, go to the next one. But we'll talk about biological effect after your exam. That's part of your second exam. So, all right. So secondary radiation, so scatter X-ray is deflected from its passage through matter. This happens clearly the majority of the time. So scatter is very common. And you have two kinds of scatter. We have Compton and Coherent. So Compton scatter is when the photon strikes a loosely bound outer shell. Now this is where it's going to get a little confusing because we talk about inner shells, outer shells. A lot of things we've talked about so far happens to inner shell, K-shell electrons. But Compton scatter is affecting a loosely bound outer shell. So star that as something different from things like, coherent or, these other, characteristic, these other kind of processes that affect, or even Bremsstrahlung that affect the inner shell. So Compton scatter, the photon strikes a loosely bound outer shell electron of matter and it ejects it from its orbit. Ionization is created, and we'll talk a lot more about ionization later. So the X-ray photon loses energy and continues in a direction, usually backwards, a different direction. So because it's a loosely bound outer shell electron, it hasn't totally wiped out its energy. It can keep going. So if Compton scatter reaches the film, it likely will produce, so after it continues to travel and kind of bouncing around like a ping pong ball, if it happens to reach the sensor, it tends to create fog because it's not very useful. It's lost some or most of its energy, and it's not a very useful X-ray photon anymore. So we want to try and reduce scatter, and that's why we have all those other mechanisms to try and get things, to the lined up the best way for the best quality picture. Let me see if my notes say anything. Compton. Okay, that's all I said there. So that's the same. So we have Compton. This is a picture of Compton. It comes in, hits an outer shell, and then it might just head off in a different direction. And then it could interact again and do the same thing until all of its energy is used up. The next one is Coherent, and its low energy photon has its path altered by matter and it changes direction. But you can see that it hasn't really interacted with anything. So Coherent kind of sneaks through without any interaction. It might change its path and then it might hit something the next time, but when it goes through and it just changes course, it doesn't actually cause any effect to this atom, whatever this was. If this was a cheek cell or whatever it was, when it's coherent scatter, it doesn't actually do anything biologically to change it. Yeah. No? Yeah, this is kind of like, yeah, it just kind of snuck through and changed direction. Now it might go hit something next on its next journey and become, Compton scatter. But when it does this, it's doesn't really undergo, there's nothing that really happens to the cell. And that you can see it doesn't happen very often. It's approximately 8% of the interactions with matter. Mm-hmm.
So all of these interactions are basically, we're saying that they could happen with your cheek or like whatever.
Mm-hmm. Anything that it hits once it comes out of the tube head and it comes in contact with the patient. So yeah, it could be the cheek or the tooth or the periodontal ligaments or the, enamel dentin fillings. Yeah, whatever. Mm-hmm. Okay. So here's just to kind of summarize it. We have the primary beam or the useful beam. It's what exits the tube head. We have the secondary beam, which is after the primary beam interacts with matter. Then we have photoelectric is when it's absorbed completely. So ionization does occur during the photoelectric effect. The beam collides with an inner shell electron and uses all its energy. That happens about 30% of the time. Then you have scatter. So there's no scatter with photoelectric. It's just goes in and is absorbed, and that's the end of that. With scatter, it's a form of secondary, and you can either have Compton or Coherent. Ionization happens with Compton because it affects the electrons. It causes ions. It makes ions to occur. So there's ionization. Coherent, there's no ionization because it just kind of sneaks through. So that's kind of a little summary of those various activities. Can't get my mouse back over to here. Okay. Any questions on all that? I know it's kind of.
With the scatter, when you say it just goes, where does it go? Do we know?
Well, it keeps traveling. So if it does keep going and happen to make it to the sensor without having done anything, then it's going to give its like full X-ray photon power to the sensor. It'll probably hit the sensor. Chances are, though, I don't know. It did say it only happens 8% of the time that it would actually like exit the person and then go hit the wall or something, which is a potential. Like it could like go on because some of that X-ray beam that you're utilizing goes beyond goes on either side of the sensor. So some of it doesn't ever even hit the sensor, not very much because we've restricted it. And so I guess theoretically it could like just make it through the patient and go hit the wall or something, but probably highly unlikely because it, once it gets it through one atom, it's got to make it through another. And like, I mean, how many atoms do we have in our cheek? You know what I mean? So I don't think it's happens. And I don't know really how you'd even tell. That's a whole science that I wouldn't even know, but yeah, but it could make it to, that can happen like going through the pulp or going through airspace or something like the interproximal space between our teeth. It could go through there, not really affect anything and hit the sensor. And then we have that dark, that's what shows up as radiolucent. I mean, yeah, radiolucent. Yes. So the secondary beam, scatter radiation is a form of secondary. And secondary is what happens after your useful beam, which exits your tube head, contacts with matter. I don't know if I should have put the photoelectric. I think I should have put the photoelectric above the secondary now that I think about it. Although no, because photoelectric comes from the secondary beam. See, that's why it can get a little funky. I mean, I tried to kind of summarize it. I think this works. Yeah, because scatter is a form of secondary, and then the photoelectric effect happens off of a secondary beam as well. Everything basically that reacts in your body comes from the secondary beam because
it's hit matter.
Yeah, it's hit matter, and then that's the next step. Yeah, it's kind of a confusing. If you guys sit and digest it and have questions, feel free to email me. And I even usually on Sundays I check my work email almost every Sunday I do. So if somebody has a question on this, or they look at the study guide and they see that you're supposed to know something and you feel like you don't quite get the concept, feel free to email me. And we can meet next week too. Okay, so attenuation is absorption. So attenuation is the reduction of the intensity of the X-ray beam as it goes through the different dental tissues like cheeks and teeth and all that kind of stuff. So high absorption of X-ray photons will result in a white area, meaning if all of those X-ray photons get taken up by, they hit metal restoration, they hit, let's see, the dentin is a lighter area, so more attenuation happens in the dentin, leaving, or no, I'm sorry, I meant to choose the enamel because that's brighter than the dentin. So more attenuation happens in the enamel, more X-ray photons are absorbed in the enamel, therefore the enamel looks whiter or lighter gray. It doesn't look white, but it looks lighter gray than the pulp or the dentin. So more attenuation, more absorption has happened. Low absorption of X-ray photons leaves a radiolucent effect. And you can see that here by, let's say, so here's air. So these are our X-ray photons flying through the air, and this is bulged out, meaning our X-ray photons have hit the sensor. Here, the X-ray photons are coming down, they hit some bone that's like a thicker bone, or, it's obviously thicker than air. And so it stops them a little bit short, but still they get a little bit farther than this bone, which is even thicker. So the X-ray photons they get absorbed and even fewer get to the sensor. So the thicker something is, the more dense it is, more X-ray photons are going to be absorbed. And then on the other side, on the sensor, it's going to be a darker area, more radiolucent area. I think I said that wrong. I think I was like just thinking about it. I was like, no, I said that totally wrong, and it's recorded. Okay.
Radiopaque.
Yes, radiopaque. So the more that they're absorbed, the bone and whatnot, then it's going to come. Thank you, Jim. Like I'm sitting there, like hearing my voice in my head going, that's wrong. So the more that absorb, the whiter it's going to look on the film. Okay. So factors in a nutshell that affect absorbing of the X-ray photons, the wavelength. So shorter, higher frequency, they're gonna penetrate better. If it's lower frequency, longer wavelengths, they're gonna be absorbed quicker. They're gonna be absorbed easier. And then the density. So you can think of it just as like enamel is denser than the pulp. The pulp has blood vessels and nerves, and it's just, soft and gooey, where the enamel is dense. Thickness of the material, or so a patient who has a big jaw, like a big man with a large jaw, their jaw is just gonna absorb more than somebody who's very small and has like a thinner mandible. And then the atomic number, so that has to do with like material, like metals and stuff. The higher the atomic number, the greater the absorption. So it's gonna pretty much anything shows up, any metal, in the mouth, I've never seen metal in the mouth that doesn't show up white. So it's pretty much all white. But porcelain shows up less radiopaque than, say, gold. So that, that shows up different. We're almost there, guys. 2 more, and then we'll take a break. Differential attenuation. So here's a cross-section of a tooth. And this picture up here is a cross-section of a tooth. You can see we have the black is the PDL. We have the enamel. We have the dentin, the lamina dura. I don't know if you guys have talked about the lamina dura. Part of the bone that shows up, this whiter part of the bone, that it's like you have the bone, then you have the lamina dura, then you have the periodontal ligament. So all these different areas, and you can see how the X-rays will go through, trying to figure out, oh, it's showing the shades of gray here. I'm like, what's it showing? So it's saying like, as your X-ray goes through the periodontal ligament, it comes out looking black. As your X-rays go through the pulp, it hits the film looking dark gray. As your X-rays go through the enamel, it hits the X-ray film looking lighter or closer to white. So here we can see metal. This is all metal, metal, metal. What's this through here? That's enamel. What's this area through here? And then what's, yeah. And then you can see we have all of this kind of webby looking cortical bone through here. Yeah. There's something condensed down there at the end of the apice. So you can see it just shows, it all shows up differently on the, and then this, what is this showing here? I guess this is just, it's just a drawing that shows the different pulp, dentin, periodontal ligament. It's just naming the different occlusal margin. So it's just naming the different parts of the structure in just a drawing instead of an actual real X-ray. Yeah. So composite usually look, so the main way that I can tell composites are because I look for the prep marks. So when you're looking at a tooth that has like a natural tooth, you'll see kind of this almost like this kind of shape that mimics the shape of the crown, but more swoopy. But if it's a composite, oftentimes it will have a prepped box out, cut out to it. So a lot of times that's what you can see.
That
Are you thinking that this is composite here?
no, like the one you said is metal.
Yeah.
How do you tell the difference between that and then one composite?
Because composite doesn't show up that white. So composite is not as dense, it's as metal. So it doesn't show, it actually shows up and looks very similar to enamel or even sometimes dentin. And sometimes if it's an incredibly old composite that a dentist put in many years ago, it will show up looking like the pulp. It'll show up dark. So it'll be like the, and we'll have some of those later in the program. This is a program later in the class next week or whatever. And so we'll have some things that show images, and it's like, what is this? What's causing this? That kind of thing. And so you'll have to. Sometimes people think it's a decay. They'll say, oh, that looks like decay, but it's actually like a really old composite that doesn't have the added. They added stuff into the composite material decades ago, really, to make it more radiopaque. So you can tell metal because it's like the whitest of the white. So if you, some that we'll see will be porcelain fused to metal. So you'll see a metal core, and then you'll see this shell that's less radiopaque, and that shell is the porcelain.
Like bright white crown.
Yeah, well, if it's solid bright white, then it's usually a full metal crown. So it's usually like full gold or something like that. But if it has a porcelain, you usually can see the two layers. But you'll see examples of it later in the program. Ignore me. Okay, so time does not allow. However, I'm like, if time allows, but time does not. So, but take these as questions. So like, this is not graded. This is not a have to thing, but you can look at these later and see if you can answer these questions, and I can provide the answers for you and post them if you guys want to see if you check your work. But like, what's the purpose of the filament circuit and the high voltage circuit, and how do they function? And test yourselves. Can you say that stuff off the top of your head? And that's also some good prep stuff for the exam. So, but I'm not going to spend time on it because we have a whole nother PowerPoint to get to. And it's 2 o'clock. We have 50 minutes, 5-minute break, sorry, short break. So come back at 2:05. Bye. Okay, so we are gonna make some fast moving lecture style talking here. Okay, there's a couple concepts that are going to take a minute to digest, but really truly it's not as heavy on the exam. And it's more practical what you need to know. I mean, it is on the exam, don't get me wrong, but it's not as heavy content on the exam. You still need to know it, but it's more what you'll be using in a clinic. I don't know what this is. Lab information. Oh, bite wing assignment. Don't worry about that. Do not, oh, that's probably just a reminder. Do not delete any images. That's just a reminder for when you're taking x-rays. Please log out of vaccine. Oh, well, these are just good. I just want to take a second to just say these things since they're on this slide, which I forgot they were on. When you start taking films in clinic on Dexter, the bottom, when you pull up a template and you have like 4 x-rays or an FMX or whatever you have, if you take your 4 films and you want to try again because one of them didn't turn out good and you want to try it again, you can take more, but don't ever delete films that you don't like. They'll just live in that bottom scrolling part. It's fine if you have 4 of them down there or 5 of them or 2 or whatever, but never delete a film because that's part of safety for our patients. We don't ever want you being like, oh, that was bad and I don't want to fail, so I'm going to delete it and just take another one, because you're just exposing your real patient to real radiation. So we never get in the habit of deleting x-rays. We just live with the mistakes and learn from them, and they can just live in that bottom scrolling part down. Yeah.
Through my talk, you guys can like remove the power from them to do that.
Yes, and they talked about that, and so you guys actually shouldn't probably be able to do it. So hopefully that's true. They used to be able with FixWin, they could delete it all the time. So, and I think everybody is doing this, but when you log out completely, you log out with that little orange logout button, and then you restart, and that clears it. So that helps with the difficulties of the software that's always having little hiccups. Objectives, I'm not going to read through them. You just go ahead and do that on your own. It's just the outline. So film size. So we pretty much always use the 2. I do want you guys to star this PowerPoint because you need to know that 0 is child and 2 is our standard size. So star this PowerPoint. We've been talking about the various types of intraoral films. So we've learned that we can take periapical or PAs. We've learned that we can take bite wings, and they can either be horizontal like this, or they can be vertical like this. And we will also learn about occlusal films, which unfortunately we don't really take because we don't have big enough sensors. We can sort of play around with it with an occlusal with the sensor. And some of you who are dental assistants probably have taken occlusal films on kids before. It's a very short, very short chapter, and we won't talk about that actually until I think the next block of lectures. And I think it's on like exam 3 or something. But that's another type of intraoral film, is the occlusal. When we take x-rays, we're using 2 different techniques. We either use a bisecting technique or we use a paralleling technique. And we'll go into much more detail, but the quick and dirty of it is that if it's a bisecting, you are bisecting or cutting in half perfectly down the middle an angle. So you're taking the angle of the long axis of the tooth and the film, and then you are bisecting the angle, the invisible angle in between. Impossible to describe until I show you some pictures. So here's a picture of it, but we're just going to get it to more detail in a minute. Paralleling is what we are doing, hopefully, ideally, when we use our XEPs, because we're setting up the film and the long axis of the tooth parallel. They're together, they're biting on the bite block here, and the long axis of the tooth and the oh my gosh, and the film are perfectly parallel. Ideally, that's what we're trying to do with our XCPs. And you can see that here. Here's the film, here's the long axis of the tooth, and then the central ray comes in at a perfectly perpendicular right angle to this perpendicular to the film. So the central ray comes straight in and it forms a right angle with this film, if everything is lined up just so. And we want that to happen with bisecting, but it takes more kind of consideration of what's going on. Okay, so paralleling, so fundamentals. So your film or your sensor is placed with the paralleling technique. Your film or your sensor is placed parallel to the long axis of the tooth. So your tooth is sitting there in whichever angle. If your tooth is flared out a little bit lingually or labally, or whatever way your tooth is tilted, it has a long axis, and you want that film to be parallel with it, like railroad tracks. They never cross. The vertical angulation with the central ray. So the central ray would be when you have your primary beam coming out of the BID, your primary beam coming out of the BID, your central ray is going to be coming the straightest, sort of. It's going to be hurtling right at the target of what you want. And that central ray is going to hit at a right angle with your film. So the vertical angulation, which is your up and down angulation of the BID, with your central rays directed perpendicular. So this up here is a perpendicular, it's a right, makes a right angle to the film and the long axis of the tooth. Can you guys visualize that? Your primary beam has a central ray. Think of it as like the one that's, all of it's kind of fanning out, but we want the one that's kind of coming right in like a homing pigeon. That's bad. That's like a really bad. I wanted to say like a missile, but a homing pigeon came into my mind. But it's coming right into the target of what we want to hit. And it's going to hit the sensor and the long axis of the tooth at a perpendicular angle, which is basically like this is a right angle right here, a perfectly right angle. Horizontal angulation is just through the contacts. It'll be, and it could be this or that or this or that or that. It's just through the contacts. You just want it through the contacts. So this down here is paralleling, because you can see that the central ray is going to hit the sensor at a perpendicular angle. This is not, because see how this angle between here and here is that obtuse? Am I right? Do you guys remember geometry, like the acute and obtuse? Is that right? Oh my gosh. So the angle is greater than 90. It's not perpendicular. Here's another image that's kind of showing the long axis of the tooth and how it is perpendicular with the film. Bisecting. So here we have this angle from A to B is the film. From A to D is the long axis of the tooth. And right down the middle, there is an imaginary line called the bisector. So it's going to be in various places, and it's something that you have to eyeball. You have to make it up in your head. You have to look at the patient, and you have to look at the trajectory of their tooth and try and get your best guess visualization of where the long axis of their tooth is headed, where you've placed the sensor, and then you have to cut it in half. We'll practice it in lab, but the bisector is the imaginary line that will then create, you can see it's a perpendicular angle right through here. It'll create a 90-degree angle when the central ray hits the sensor. If you get your angles right, now it's very hard to get your angles right, and that's why we have distortion with bisecting, but we kind of just calculate that in. We just know that that's going to happen because it's hard to do. So that's what it's showing here. Here's the long axis of an anterior tooth. Here's the film. And they have created the central ray in such an angle to come down and hit the film at a 90-degree angle, or hit the bisector at a 90-degree angle. So you're not, oops, sorry. So you can see sometimes this is what gets confusing to people is they think, I need my central ray to be perpendicular to the film. Well, that's only with paralleling. With bisecting, you want your central ray to be perpendicular to the bisector, which is halfway between the film and the long axis of the tooth. So you're trying to line up perpendicular with this imaginary line that you've guesstimated where it is in the patient's mouth. I know. It's not that bad, actually. It's when we do it in lab, it's actually not that bad. It's a confusing thing to think about in the beginning, but it actually is, it's okay, really. Trust me. Okay, so bisecting technique. So fundamentals, head positioned, so we were talking about this, Teresa was talking to you guys, make the occlusal plane parallel to the floor, get your patient really stable, get their head so that they can't move their head back, and get their occlusal plane parallel to the floor. Your film or your sensor is placed on an angle against the incisal edge. So usually, I wish I had my XEPs, but usually when your patient bites down, remember how I was kind of showing you guys when you're doing your proficiency? I know like 2 of you haven't had your, don't worry, we'll cover it. But when you do the proficiency and your patient bites down, they bite down maxillary and mandibular on the bite block. But when you're doing bisecting, the incisal edge gets more to the kind of that corner area where the film will be seated, and then the tooth comes in real close to the film. So that comes in real close to the film, and then that's what helps to create that angle. So you can see how it's kind of demonstrated here. Typically, this is your film, and there would be more space there, right? This is where the bite block would come off, and the incisal edge would be over here more, so that the film and the long axis would be parallel. But here it's coming in real close to the end of the film. The vertical angulation with the central ray is perpendicular to your imaginary bisector, and the horizontal angulation is through the contacts. So that'll vary depending on how you get through the contact. Yeah. Mm-hmm.
Can you tell us the time when we might need to use it?
Yes, that is coming up in this slide deck. So yes, film placement is in the center of the film. Your sensor is behind the area to be photographed. And then your vertical angulation is standardized. And the reason why this is standardized is because if you set these things up just so, typically, if you're too steep or you're too flat, you're going to have more distortion. So they give you these standardized degrees, and well, that'll come up in the slide here too. It's hard because some of these you have to get through the slide to get to the question that you might have. So here's the standardized vertical angulations for the maxillary teeth. So what we're talking about here is how you're moving your BID up and down. That's the vertical angulation. And there's that dial that has some numbers. And we've been telling you to set it to roughly 7 to 10 degrees for bite wings. So like a gentle slope of your BID, that's like 7 to 10 degrees. But now you can see here, if you're taking a central incisor, and you do not have to memorize these degrees. These are not going to be on your exam. You don't have to memorize these different degrees. But when you're but you do want to have them handy for reference when we practice bisecting in lab. So you want to bring your book with you, or just like print it out or something. So if you're taking a central incisor, you're going to be 40 to 50 degrees downward. If you're taking a premolar, 30 to 40, and 20 to 30 for a molar. So the more anterior, the more sharp your angulation of your BID. So this is just going to make a lot more sense when you actually get to do it hands-on. You can see it changes. Now you're going upwards for your mandible. So your BID should be pointing more up when you're doing your mandible, a little more down when you're doing your maxilla. So here's just a shot of the tube head. The degrees is on the side, and this is what it's referring to. Numbers above the 0 are positive, numbers below the 0 are negative. So when it says negative 30, you have to turn it to 30 on the underneath, below the 0. And then it'll lift up the head and the back of the tube will come down and you'll be at a negative angle. Okay, so here are some images showing how it might look in the patient's mouth. The incisal edge is close to the film. They've determined about where the bisector is. They've made their central ray perpendicular to it. And this is about how steep. You can see it's pretty steep, but it's flatter when they're doing a molar. And here, again, the occlusal surface of the molar is close to the film. Figured out about where the bisector is, perpendicular to the bisector. And then here's the film. You get some distortion. You'll see more distortion with bisecting. Sometimes the palatal root, which is usually always distorted, will get even longer looking, like be even more distorted. So which one of these, 1, 2, or 3, which one is has the correct bisector? You got it. Yep, 3. 3 has the correct bisect. That's bisecting the angle. So advantages of paralleling, which is preferred. This is what you're ideally trying to do with your XCP. The advantages are there's minimal distortion. You get a truer image on the sensor. The tooth and the film are easy to see. And the direction of the X-ray beam it's easier to like line everything up. And then there's many different film holders. So you get, the ones that you guys are using, but there's so many different ones. There's sticky ones and ones that the sensor slides in on one side, but not the other. I mean, there's lots of different holders. You can use a snap array too, but you're not going to have the XCP bar with the snap array. Disadvantages for the paralleling. Sometimes you can't get it parallel with the long axis of the tooth, depending on the patient's anatomy. Sometimes you need to go back farther in their mouth to get that parallel relationship, and the patient gags, and you have no way of getting back posterior enough to make that parallel relationship. So even with your XCPs, you very likely might end up bisecting inadvertently and not even knowing that you're doing it or paying attention to the angulation. You just ended up doing a bisecting. And maybe it wasn't a great bisecting technique because maybe there's quite a bit of distortion, but you may just end up doing it because of the difficulty of your patient's mouth. You just can't get your XCP or your film where you want it. So if they have a small mouth, a low palatal vault, shallow palate, presence of tori either in the palate, they have a single bone in the palate, or if they have the bone on the inside of their mandibular ridge, kind of bumpy bone, and you can't get the sensor in there, they gag. The patient might complain more. And so you're just trying to adapt your ability to get the sensor in their mouth to their situation. That might throw you into end up taking a bisecting technique, even if you don't mean to. Advantages of the bisecting is that you can usually get the sensor closer to the tooth and kind of more out of the mouth. So you're not, in order to get that parallel relationship, you have to have it just so. But if you can scoot the whole apparatus kind of closer to the tooth and kind of more away from things that will cause them to gag or be uncomfortable, the patient will like it better. But the disadvantage is you're going to have just a lot more distortion. You're going to have more elongation of the tooth, more stretched out tooth, or more foreshortening, kind of a squashed, short looking tooth. You're just going to get more distortion. Estimating location of imagery bisector may be difficult. Oh, so it's just hard to know where the bisector is sometimes. That's just saying sometimes it's just really hard to figure out where the bisector is. And so you're just kind of making an educated guess. So film criteria. So this here, I am going to spend very little time on each slide here. If I have time, if I get to the end and there's still a few minutes left, I may circle back, but you just need this. This will correlate very nicely to that sheet that I handed out to you guys, this one. This will correlate very nicely. Yeah. So it says central incisors. So here's your central incisor film. I'll just talk through a couple of these, but then I'm not going to spend too much time on each one because it's just information that it's things that you want to know for criteria for each film. So center film, the sensor is centered in the midline. So this is your midline, and it's centered in the film. Your key contact is between the central incisors. So this, you want to go for this. If you have a little overlapping in the laterals, that's common, and you might be able to open that up when you do your canine shot. But your key contact is your central incisors. The apex, you always, no matter what PA film you're taking, you always want to have 2 millimeters of bone surrounding the apex minimum. That's minimum. And then you want to see the crowns of your central incisors. So you want to see full crowns. Oh, wait, hold on. And then you have, here you can see about where they placed it. Here's your BID up against, and here's the sensor. And then it's showing how the sensor is pretty parallel to the teeth. Here's a side view. The sensor is parallel to the incisors, and the incisors are biting on the top and the bottom of the bite block. Now, if this was a bisecting, this incisor would be all the way in here, and you'd have this part of the sensor would be a little bit farther out of the mouth, and this angle would be a little bit more steep. So everything, all the angles change with bisecting, but you can see how this is going for the paralleling because the film and the tooth are pretty parallel. This is a cotton roll, and this is used sometimes to help patients who are having difficulty biting down. You put the cotton roll on the opposite arch, so the bottom of the bite block, basically. So if you're going for maxillary teeth, you want your cotton roll to be under like, and they'll bite it with their mandibular teeth. Okay, so for a canine, so again, we have criteria: center the canine in the film. The key contact is between the canine and the lateral. And then the contacts to open the mesial of the canine, that's what we're really going for, is the mesial, because we'll get the distal of the canine in our other shots. But this is the only place where we can get the mesial of the canine. Apex and crowns of the teeth visible, 2 millimeters of bone. Note the distal contact of the canine is almost always closed. So I think this is that one exception of if there is horizontal angulation, you don't have to mark it as an error. But everywhere else, with every other film in the whole mouth, you would mark horizontal angulations everywhere and anywhere. But with this one, because it's almost virtually impossible to get that open, they've just, for whatever reason, just made that the exception. So if you do mark it though, I would never mark you wrong for having said that's horizontal angulation. I wouldn't mark you wrong for it. Okay. So here's just an image of a canine shot. Canine is centered, contact is open, distal is closed. Premolars, just criteria there. Key contact is between your first and second premolar. Contacts to open mesial and distal of the premolar. Here, you got the distal of the canine, opened up all the contacts. This is a little overlapped, but overlap too. Diagnostic. Film criteria for the molars, position film. So second molar is centered. The second molar is centered on the film. Anterior edge of the film is close to the mesial of the first molar. This, I guess, is different from what the book says. I'm not sure exactly what the book says, but when you're placing your sensor in the patient's mouth, just try your best to center that sensor on the second molar, and then notice that the anterior portion of your sensor is likely toward the mesial of the first molar. That's generally how it should line up. I'm not sure what I have to review what the book actually says. I don't really remember why that's different, but that's our criteria for sure, is to center the second molar. Key contacts before the first and second molar, and trying to open mesial and distal of all molars in the picture, ideally, and 2 millimeters of the apex. It's not necessary to see the mesial of the first molar. Star that, you'll need to know that for the exam. it is not necessary to see the mesial of the first molar on a molar film. And why do you think that is? Oh, well, it says it right there. Why do you think that is? You'll have to read. Because you'll see it on the premolar. You'll see it on the premolar film. So here is a typical molar. You do see the mesial of the molar here, but for some reason, if it wasn't there, it would not be like an error or a retake. You wouldn't have to, because you will, I mean, if you didn't get it in your premolar, then yeah, you'll have to take it again, but you can cross that bridge once you know how your premolar shot turned out. Very likely you'll see the mesial of the first molar in your premolar shot. Here it says it again. It's not necessary to see the mesial. Not going to take time to critique. We'll do that in lab. You guys are getting pretty good at you've taken the critiquing for bite wings. That same, we'll talk about it here a little bit still in the PowerPoint, but you take that same concept and you just put it on PAs, and we'll do it in lab together. But there's just not any time to do it right now. The goal is so we have to talk about the difference between critiquing for errors and then deciding what needs to be retaken, like what constitutes a retake. So the goal is to retake as few films as possible. So when we take a set of 4 bite wings or we take an FMX, there could be errors all over the place, but it's still diagnostic and we don't need to take that many retakes. And so we have to determine that. So there are 2 different categories. Retakes to actually expose the patient again to get something that we're missing is totally different from just critiquing for errors. I said that. Okay, so we know the errors. We have horizontal, vertical placement, and beam centering. Closed contacts or overlapping is our horizontal angulation. If your overlap cross, okay, so this, I think this might need to be edited. Let me read it out loud and see. If your overlap crosses the DEJ, which these do, this is a pretty bad film, but this overlap is deep enough that it has crossed over the dentin enamel DEJ. So if your overlap crosses the DEJ and it cannot be seen anywhere else in your FMX, so you've taken an FMX and you've checked every picture that has tooth number 12 and 13, the bite wings and the PAs, you've checked those, and every single one of them, it's overlapped over the DEJ, that film will have to be retaken. If your overlap does not cross the DEJ, it is still an error, but does not require a retake. This does need to be edited. What it should say is this. You have to write it down. What it should say is if the overlap is more than a third through the enamel to the DEJ, so the overlap is greater than 1/3 of the way into the enamel, likely the dentist will want you to retake it. So that is your criteria, not if it crosses over the DEJ, but if it goes into the enamel more than 1/3. Because we used to have it be, clearly it used to just be within the enamel, and then we reduced it to halfway, and then a couple years back, they reduced it to 1/3. So now if you have a film and nowhere has the overlap been less than 1/3 of the way into the enamel, then very likely they're going to want you to retake that film. There are a lot of situations in clinic where they'll say, I've looked back like 3 sets of films, nobody has opened this contact because it's just the way their teeth are in their mouth. Then they might give you a pass and you might not have to take it again. So it's an individual thing, but for the exam, it's not just if it's before the DEJ, if it's more than 1/3, then it is a retake, technically. Okay.
So I should say, if your overlap is more than 1/3 into the enamel, it's more likely.
Yeah, exactly. Yeah. Sorry, I will edit this film or this slide. Okay, so some images here do this. You want the beams to go straight through the teeth to hit the film. So see, these are all perpendicular angles right in between the interproximal space. That's why the contacts are open. Not this. They're coming in at an angle. You're picking up a little bit of this and a little bit of that, and that's what's making the overlap. So that's just demonstrating that horizontal angulation. And then foreshortening, what is the error and how can we fix it? So I have a concept in my mind that I think paints kind of a nice picture of what's happening with the beam, but I don't know if it's good to say it first. Basically what is happening is you're either too steep or you're too flat. And so you can see here with the foreshortening that okay, now I have to think about it for a second. They're too flat. So if they're too, oh shoot. So if they have foreshortened the images, then they are too steep. If they've foreshortened the images, they are too steep. And so what's happening is, and I have a picture. I'm going to see if I can draw it here on the doc cam, because I think I can kind of make an image drawn a little bit better than trying to explain it. Let me use the back of this. Okay. So when you have the film, and then we're going to write film here, and then we have, here's this light block, and then we have the tooth. I would draw a tooth, but it'll probably end up looking funny. Looks like a ballet flipper. And we have a tooth. If the beam is, and then what we have is if the beam is centrally coming in, that central ray is coming in perpendicular, the image of the tooth, this is the weirdest looking tooth in the whole wide world. The image of the tooth is going to basically come in here and here. It's gonna hit the film in the exact similar proportion of what the actual tooth is. So you have this kind of perfect range here. Now, if your film is coming in, your X-ray beam, let's say our PID is here, here's our PID, and your beam is coming in very steep. See, I kind of almost had to draw it out in order to think about it. If it's coming in steep, then what you're going to get on your film is going to be foreshortened. So your beam is too steep, and you're going to, so now this area here is going to squish down your actual real size of your tooth, and it's going to squish it down and foreshorten it, and you're just going to have this smaller image that's kind of been compressed and smushed down because you're too steep. And so what you would have had if the angle was right, if the central ray was perpendicular, when you would have had this showing your original film here, I wish I had two different colors. Here's two different colors. So your original one is red. This is your central ray being perpendicular. This is what you want. But now, foreshortened. Now you've smushed it down like this. So now the beams that are coming down have squished down the size of your tooth like that. Now, if you have your film if it's too flat, then sometimes what you end up doing is the picture actually, it takes the picture and it stretches it. So you have your beams going in the opposite direction, and it'll stretch it from one part of the film up higher in the film because of the direction of the beams. I actually think that we talk about this in a little bit more depth, and there's some there's some examples. One thing that I talked about last year that I feel like kind of helps is if you think of the sun and shadows. So if you think of a tree and you think of when the sun is at the horizon and it's the sun ray beams are flatter, then you have a longer shadow of your tree. You can actually kind of practice this. You have a question, Tala?
No, I was gonna say, this might be a 6 months ago, but then if you look at the camera on the phone, the first one was
Yes. Oh, then maybe I'm complicating this. I might be complicating it, but it is. So it's the same kind of a thing. And then you can use lots of different explanations. But when like the sun, as the sun goes higher in the sky, if you were to look at the shadow of the tree, it gets closer and closer to the trunk until it's like, you know, it gets shorter and shorter and shorter and shorter until it's like absorbed inside of the tree. So I do think that we talk about this a little bit more. And I think there's some examples. I don't remember if it's in this PowerPoint though. But this is an example. Here you can see both of the cusps. You can see a little bit of the occlusal surface, and you can see how the roots are very squashed in the foreshortening. And so that's what happens there. Now, in the next one, this one is elongating them. You can see that the roots kind of go like kind of stretched off and they kind of get blurry at the tips. So that's one thing that you'll see sometimes, that it'll be so elongated that it stretches it right off of the film. But a lot of times if it's not off of the film, you'll still see like this kind of distorted, blurry appearance at the apex. So that's what, and there it's too flat. Okay. This is a picture of what we were kind of talking about in radiology when we were looking at critiquing, and everyone was like, is this vertical? Is that vertical? I'm like, you don't really see vertical angulation very often, but but there was a film that had like the tiniest bit. Basically, it's when you get an overlap of the cusp. So here's a pretty good example of vertical angulation with bite wings. Vertical angulation is foreshortening and elongation, and that's the dominant error that you will see predominantly in the PAs, not in the bite wings. You just don't see it as much in bite wings. Tips to determine vertical angulation errors. So look for extreme cusp separation. Check the same tooth on the opposite side of the mouth and compare sides. Things should look similar, right and left. Maxillary molar projection, the lingual root, the palatal root or the lingual root in the maxilla is always going to be a little elongated, always going to have some distortion there. But if it's like giant compared to the buccal roots, then you know that, sometimes that's nothing you can do about it. If it's the way that the roots are positioned in their head, maybe there's nothing you can do about it, but usually you have to compensate somewhere so that you can get all three of those roots visible in the X-ray. Mandibular anterior projection will often see the border of the mandible. So sometimes you'll see the bone, the border of the mandible, it'll end, and then there'll just be dark like space. And that's because maybe you've gone underneath too vertically. And so you're really, really zoning in on the bone here in the front. And so you want to come up a little bit more so you can get more of like the chin and the actual real length of the teeth. But that's a common thing that is seen. So here we have some more technical errors. This one, there's various things happening. Usually it's positioning. It could be positioning of the PID, so they're not getting it parallel, so that you're not getting the occlusal surfaces of the teeth. If it cuts off the just the tiniest edge, and the doctor can still see the interproximal space, typically you're not going to have to retake that. If it's more than 50% of the crown, like here, you're going to have to retake that. This patient probably didn't bite down far enough at all, and so they didn't seat the film deep enough so that they couldn't get the apices. So you can see you don't see any, there's some foreshortening going on because you can see some of the occlusal surface and you cannot see the apices of those roots. So that That's a definite retake. These are all definite retakes. A placement error can be any of the following: missing crown, mark as an error, but only retake if half or more of the crown is missing. Missing apices are always going to be needed to be retaken because it's very important that you see the apice, make sure there's no abnormalities or an infection at the roots. So you're always going to have to retake if you're missing an apice. And then, not forward enough or not back enough. Shade the area of the box that indicates the direction the film should be placed. And we've been talking about that. So yeah, Anna. There's like 5 questions at the end of the exam that shows like one film, and it will say like, what is the error in this film? And then your answer will be, it'll be a multiple choice still. And so you'll say, it'll be like horizontal angulation and placement error, or horizontal angulation only, or whatever you think that the errors are. And there's like 4 or 5 of them at the end of the exam, but it's still multiple choice. It's time. Okay, hold on. Let me just, hold on. Let me just throw myself through these really fast. Let's practice technique, errors, cone cutting, criteria for the FMX, supplemental x-rays. This is just saying that if you have centered your second molar, if you have centered your second molar and your third molar is there and you can't get it, it is not a ding against you. You do have to take another film, but it's called a supplemental at that point, not a retake. That's what that is saying there. We'll talk more about this. This is the radiograph technique PowerPoint. It's under week 3. So all of these films, you guys, all of this that's left here, this is all about critiquing. So this is information you should be able to handle on your own. This is all, and then mounting. But I do want to go over mounting, but there is no mounting questions on the exam. So we'll go over mounting. We'll go over mounting next time. Because I do want to talk about this in person, because there are some things I want to drive home, but there's no mounting questions on the exam. But do look at it just for whatever, for fun. But it's time is time, and I don't want to keep you guys. Sorry that I ran down to the last second.